Hello students, this is Dr. Anoop, your Psychiatry faculty at DocTutorials, and we are today into the FMGE Psychiatry MCQ discussion, and now we have the December 1920 period Psychiatry MCQ discussion of the FMGE. So almost something like a 7 questions are almost there, and let us go to the first question. So a female was brought to psychiatry after 3 weeks of delivery. She has fearfulness, irritability, getting suicidal thoughts. What is the diagnosis? There is postpartum blues, postpartum depression, postpartum psychosis, schizophrenia, 4 options given. So first of all, let us rule out schizophrenia. There is no evidence to mention anything about schizophrenia where there will be having prominent delusions, hallucinations, mainly the third person auditory or hallucinations auditory modality. Then delusions like persecution, control, etc. The thought phenomenon, thought broadcasting, thought insertion, etc. Typically for you, this will be the usual history that will be given about schizophrenia. For details, you can go into my lectures on schizophrenia in our sessions. But typically, the question I have told you that typically for you, it will be prominent delusions, delusions of control, persecutions with prominent auditory, third person hallucinations, etc. Thought phenomenon, the Schneiderian first rank symptoms. That will be the typical symptom profile that will be given to you with the diagnosis of schizophrenia. So here it is very clearly that it is brought to you postpartum period. So peripartum psychiatry is one of the important area you should know. So regarding the postpartum psychiatric conditions, 3 major things you are supposed to know. One is postpartum blues. Second is postpartum depression. Third is postpartum psychosis. It is very important to recognize these conditions. Postpartum blues occurs in about 50 to 70% of individuals. Postpartum depression in about 10 to 15%, whereas psychosis is found to be about less than 1%. So how does this postpartum blues begin? How will be the history given to you? In a woman following delivery, this starts in 2 to 3 days. Almost 50 to 70% of the females experience this condition. The problem the present will be sleep disturbance, irritability, anxiety, mood changes, etc. Some anxiety, feeling sad at times, sleep disturbance, mood changes, all those things causing some distress to the individual, and you see that it usually resolves in 2 to 3 weeks. As early as 2 or 3 weeks it's used to, or less than a month it resolves. The changes will be transient, will be like a transient sleep disturbance, irritability, some anxiety, worry, mood changes, sometimes interspace of sadness, some mood changes, etc. But relatively mild and does not cause much impairments, and with good support system, with good all support system, it tends to be resolved in a matter of 2 to 3 weeks. And now coming on to postpartum depression. This occurs usually in less than 3 to 6 months within the postpartum period, and usually you see even 10 to 15% of the cases. There, what you get will be like depressive symptoms. So what are the features of depression? the persistent low mood, the sadness. One of the core features in depression is anhedonia, not able to enjoy pleasurable things. So how does it reflect? Decreased bonding or care of child. Even it can present with irritability, anxiety, even fearfulness, worries, all those can come. And one of the important problem or the worsening is that there can be risk of suicidal risk or suicidal thoughts, risk of harm to self and baby. At the heights of worsening, even the mother may feel, I am not worthy of being a mother. I cannot take care of my child. I am not having that mood, energy. I am feeling sad, unhappy, uneasy. I am not worthy to live. They may have marked guilt that I am not able to take care of the child. They even think of why spare this child in this world and let him suffer. I will kill him, or even they may commit self-harm, etc. So all these things are very important. Many times the sad thing is that even at this current in the era, sometimes it goes unnoticed, even goes unnoticed, and that will worsen to the extent of, like as in depression, the worsen to the extent that marked impairment, risk of self-harm, self-neglect, etc. And in this case, it is not only the mother, there is also a baby. So this prominent suicidal thoughts, depressive symptoms, irritability, anxiety, fearfulness, all those things, the poor bonding and the poor care of the child, risk of harm of the child or self, etc. can happen. So all this is constitute the postpartum depression, many times won't be noticed. Postpartum psychosis, on the other hand, will be more like a psychotic symptoms. The initial phase, it will be like the same, like sometimes even the depressive or psychotic postpartum psychosis, the initial presentations may sometimes some overlap. The changes like changes in the sleep, changes in care, everything overlap. Sometimes the mood, irritability, all overlap. But as it prominent, psychotic symptoms like delusions, hallucinations, etc. all this can happen. Poor attachment to child. The subject may experience fears that the child is not mine, the child is turned into something else, etc. is not mine, is not human. Sometimes they may hear voices like the child is a threat, etc. They start hearing voices. They develop some false fixed beliefs against the child. They fear harm towards the child, etc. by others or etc. They fear changes in the child, transformations in the child. They fear have auditory sometimes experiences. All those things can happen. So, and they can have poor attachment to a child. There is a big risk of homicide. There is also risk of suicide, homicide. There is risk of homicide because they may even, there is a risk of homicide or killing the child can happen because even thinking that the child is going to be a harm. So killing child can happen. The presentations will be more sort of a florid. Usually occurs in less than 1 to 2 months, usually less than 1 month as early, maybe more florid, and usually less than a span of 1 to 2 months it presents. Less than 2 months or 1 month, the symptoms usually present, etc. So both these conditions, all these conditions requires treatment, whereas in the postpartum blues, it requires like a support and watch for any development of depressive symptoms. Sometimes it can progress, but most of the cases it settles down. Good support system is fine. Whereas in postpartum depression, we may require antidepressants, treatments, etc. will be there. Whereas postpartum psychosis, antipsychotics. So here, like sometimes like antidepressants, here antipsychotics, like olanzapine example. Whereas here, like sertraline, these are some examples, say for drugs that are given, and needs to watch for any worsening. Ensure adequate care of the mother, baby. That is very important. The risk of suicide, homicide, etc. which should always be considered and should be taken care of. So here in this question, in a span of 3 weeks, developing fearfulness, irritability and suicidal thoughts, considering the prevalence, the more common postpartum depression will be my concern. So, you should be watchful about the symptom profile of depression, psychosis, etc. A psychiatrist will take a detailed history. For a psychiatrist, these three things won't be satisfied. He have to take a detailed history, everything from. But this suicide, never I will think of a postpartum blues, because the suicidal thoughts. These are the provenance of suicidal thoughts is one of the important thing that should be considered. Fearfulness, irritability need to be explored. It can be seen, this is anxiety and irritability of depression, or sometimes it can be a psychotic picture. It can be maybe a psychotic picture. We need to watch for what is more and more fear about. But considering the prevalence with this available information, I would be going more for postpartum depression. So, had this question says that the baby is transformed, or believes that child is not hers or changed, or features of hallucination, all those things etc. was there, then I would be more concerned about the psychosis, postpartum psychosis. Typically, the questions used to give a florid presentation of a psychosis for easy understanding of the candidate. So, that brings to the end of the first question about the postpartum blues, depression, psychosis. Coming on to the second question. A 25-year-old male had an RT, a road traffic accident. After that, he is fearful of driving vehicle and going to that place since 6 weeks. So, going to that place, driving vehicle, he is fearful now. He is having flashbacks of incidents and not going to office also. So, there is post an event like RTA. It may be sometimes a catastrophic event. That means an event that can affect life and integrity of individual. So, what are catastrophic events? Flood, terrorism, war, rape, bombing, severe RTA, calamity, all those things were bloodshed, injuries, wars, all these things, following which patients can develop certain trauma related conditions. So, what you can develop is called as acute stress disorder, post trauma related stress disorder, or post-traumatic stress disorder, post-traumatic stress disorder, PTSD. So, what are the features, or what is the difference between acute stress disorder and post-traumatic stress disorder? They have some common features. That is, it should occur following an exposure to a catastrophic event that affects the life and integrity of the individual. There are 4 major symptom clusters. One is called the intrusion symptom. That is, they have intrusive dreams, memories of the event, flashback. That means as if like they have dreams and as if like re-experiencing the event again. They experience the same, that sound, the movement, something extra of that accident. Next is avoidance symptom. They try to avoid anything that will remind them of the incident. Maybe traveling in the car, or maybe that place, or anything. If they see that place or anything about in the picture, they may get reminded of that. If they think of driving about a car, they get reminded of that. Or anything that remained, all those they try to avoid. So, they try to avoid anything that will remind them. Next is negative alteration in mood and cognition. That means there is a negative alteration in their mood and their thinking. They are not able to experience happiness, feel happy, not able to enjoy everything. They feel emotionally numb, disconnected, feeling detached, everything. not able to think, be happy, not able to be fine. So that is negative alteration, mood and cognition. The fourth one is the adrenergic, the hyperarousal symptoms. That means irritability, sleep disturbance, easily getting startled, difficult to concentrate, some sort of the panicky symptoms, all those things. I have discussed in the class notes this acute stress disorder and post-traumatic stress disorder. So this 4-symptom cluster should be there and it should develop following the exposure to the catastrophic event. If the exposure to the event is required and this 4-symptom cluster should be present for this, then what is the difference between this acute stress disorder and a post-traumatic stress disorder? So there comes the word timeline. What happens to a timeline? Following that exposure to the event, if the symptoms occur in less than 1 month, then you call it as acute stress disorder. So following the exposure in 48 hours or maybe 3 weeks, 2 weeks, 1 week, etc., if the symptom comes, it is called as acute stress disorder. If the symptoms persist beyond 1 month or begins after 1 month, so that is the cutoff, the 1 month. So till 1 month it is acute stress disorder, but if it is after 1 month, it is called as PTSD or post-traumatic stress disorder. So the cutoff is about 1 month period. So the catastrophic event and the symptom profile are similar, but up to 1 month you call it as acute stress disorder. But if the interval is more than 1 month, either as it persists or begins, it is PTSD. So if the symptoms in this question, it is now 6 weeks, more than 1 month. So if the question is that if it started after 6 weeks also, or if it is persisted beyond 4 weeks, it is both PTSD. So to make it simple, if the symptoms started after 6 weeks of exposure, you directly call it as PTSD. If the symptoms started like 3 weeks after this exposure, you call it as acute stress disorder. If it is persisting beyond 1 month also, even after 1 month also, that is even after 1 month of exposure also, that is after another 1 or 2 weeks also it is persisting, you revise the diagnosis of ASD to PTSD. So this is what is called as post-traumatic stress disorder. So this may be the confusion between the ASD and post-PTSD. The 1 month is the distinguishing feature. That is a distinguishing feature. So now we are going on to the third question. A person is unable to find pleasure in doing the old activities which he used to enjoy earlier. What is this? So this is called as anhedonia. It is one of the major symptom in depression, one of the core important symptom in depression. That is inability to enjoy previous pleasurable activities. So for diagnosing of depression, you may require several symptoms are required. There is a criteria like person, low mood, anhedonia, easy fatiguity symptoms, etc. There are a lot of symptoms for so much duration. But anhedonia is one of the core symptom where this is inability to enjoy previously pleasurable activities. Depression is a diagnosis and anhedonia is one of the important thing. Alexithymia. It is described as inability to describe one's own emotions. A patient is not able to explain or describe what he feels. It's called as alexithymia. Derailment. That is a thought disorder. So what happens in derailment means that is when there is a loss of logical connection of thoughts. So what happens? It slips from one thought or idea to other. So it is like in a rail, if a rail is going in, the train is going in a rail, derailment, it slips off. So how will you detect derailment? It is from a speech sample. So if like I am asking you, okay, where are you coming from? So the patient tell, I am coming from Hyderabad. Then I am telling, okay, tell me about your place, Hyderabad. What is special? What? Tell me about the place. So typically expected places like I am coming from Hyderabad. Hyderabad is a beautiful city. It's a capital of like Telangana. It is ruled by so and so minister. It has the so and so monuments. It has beautiful so and so. It is famous for etc. These are typical things. A logical connection of thought sample you expect. You get. You connect from one thing to another. But here what happens? I am telling Hyderabad is my place. I like to play football. Football is a wonderful game. Today now the World Cup is going on. But do you like chutney and with and idli vada? That is very tasty. I often used to take that etc. So from one thing to another it goes without a connection. It gets slipped and goes. That is called as a derailment. So the logical connection is lost. I hope you understood. Like how do you play cricket? What explain? Tell me about cricket. You tell that. So cricket is played between two set of teams, maybe two countries, people, etc. Each team has so and so. Standard game has so and so 11 players on the side. So there is like each player has so and so. There is a captain. Like you put a toss, etc. Then one team bat, one team bowls. So what is runs? What is that is how you logically connect and tell. But from one thing, you start with something, you give to another, you go to another, which was having any relation to what has been asked. So that is how you get derailment when you do an interview. It is important in several psychiatric diagnosis. So I'm not going into detail, but since it was asked, I just explained. So this is known as anhedonia. So alexithymia, inability to describe one's own emotion. Depression is diagnosis. Derailment is a loss of logical connection of and which thought slides to another thoughts lacking a connection. So I hope that is clear. Coming to the fourth question. A patient has a long-term history about waking up in the night and thinking that his family going to meet with an accident. What is a probable diagnosis? Many times it is much difficult to diagnose with one or two lines that is given in suppose entrance question. Maybe if you ask this question to psychiatrist, he may find it more difficult. But let us see what can be information can be derived. So if I am here to answer this question, I will surely rule out adjustment disorder, because adjustment disorder is the behavioral and emotional problems that is out of proportion to expected, that occurs following an exposure to understandable life event. If to make an answer of adjustment disorder, a typical question will be like a person who is had an understandable life event, traumatic event. For example, like loss of money, loss of wealth, loss of job, diagnosed to have a serious illness, failure in exams, etc. So they become marked, distressed, sad, etc. But it is not person like depression, but it improves transiently, but it is causing dysfunction to the individual. A differential diagnosis is depression where there is persistent and pervasive involvement of symptoms, but here there will be transient ups and downs with transient improvements, etc. But causing distress and emotion. And even after a period of time, you expect that things will improve, still it is causing dysfunction. So for details, you can look on to my notes. Then comes next thing is panic disorder. I will rule out panic disorder because from previous discussions, I hope you understand. It is like an abrupt episodic event that happened and causing, and the question should have intense autonomic somatic symptoms. A question should be like he has woken up in the night with palpitations, sweating, uneasiness, not able to relax, pounding sensation, feeling that I will die now, something is going to happen. He is going to have a heart attack, etc., which settles after some time, etc. This will be the typical question that should be given for panic. Now comes OCD and GAD, or generalized anxiety disorder. What should be there for OCD? For OCD diagnosis, there should be, the question should ideally contain a repetitive intrusive thought. which the patient recognizes as irrational, coming in his own mind, which he cannot resist, difficult to control, following which he feels compelled to do something or not able to control, causing dysfunction, etc., is the typical history. Sometimes after seeing this question, you may feel some sort of an obsessive quality that waking up in the middle of the night and thinking his family is to meet with an accident, etc. A particular maybe a fear, but that does not typically qualifies for a clear OCD where it should come repetitively, causing intrusive, which is difficult to, and the patient experience more of that difficult to control, understanding it is senseless, but it is still keeping on coming. Understand that it is not a senseless thought, but that thought is particularly coming, not able to control. It comes at different times, not just waking up in the night and at a time, and makes a patient do something to neutralize the fear, etc. Those things are typical ways that are given to you for diagnosis of OCD. So I will rule out that also. Now comes generalized anxiety disorder. GAD usually has a long history. It will be having a waxing and waning. It should be having a fluctuating course. There will be more of a persistent worry. The worry is not restricted to a particular thing, but free floating anxiety. It's a worrying about multiple things. And the subject should be having apprehensions and anticipatory worry. That is, something bad is going to happen. They anticipate this will happen, this will connect to something, and that will happen. When I go there, then this can happen, and that will bring bad things, etc. So, anticipatory worry. Today, when I need to travel tomorrow to that place, that time I am sure that sometimes I may meet with an accident and I may die. Or in that case, what will my family do, etc. So sometimes it can be generalized. So what about my future, about my family, something bad will happen. A lot of things, not specific, but more generalized, and that can happen. But there will be some elements of specificity in apprehensions, like sometimes will my family meet with trouble, and etc. can happen. They may have somatic symptoms, that is muscle tension, insomnia, headache, etc., not able to concentrate, etc. So these are the features of GAD. So specifically speaking, with the available information, I would like to go for generalized anxiety disorder because of a long-term history about waking up in the night, thinking that something bad is going to happen, etc. So I may go for GAD as a diagnosis than OCD. So this will be my choice in this condition. Whereas for a question of OCD, I expect this symptoms coming up in more frequency, not like in the middle of the night once, but more frequency. And it is repetitive, intrusive, comes frequently even in situations not expected, and that particular thing not able to control. Many times you understand, but it is senseless and has no purpose why this thought should come. It is often appears senseless and irrational, but it is difficult to control. The more they try to resist, it is causing intense distress. And in some cases, they try something to neutralize this worry, etc. So this is what typical OCD questions you used to get. They won't usually, I hope the examiners usually won't confuse you, and they expect an answer of GAD in this scenario. If with the available wordings of the question, if this is correct, this is the expected answer. Going on to the fifth question. 20-year-old female scared of elevator since birth, prefers stairs instead of elevator. Acrophobia is the fear of heights. From this question, I perceive that it is not the patient having problem of heights. It's not the height, but elevator is a problem. It is not having a problem with going by the stairs to the height. That is not a problem. So I can rule out that. Social phobia, also known as social anxiety disorder. What is this? In social phobia, it is fear of being in socializing situation. It can be specific or diffuse, like talking in a crowd, making a presentation, talking to opposite sex, etc., eating in front of public, etc. Here in this, what is happening is subject feels anxious. The subject is having anxious and all the manifestations. At the same time, he fear being noticed and negatively evaluated by others. So, if you ask a patient with social phobia, what is your major concerns? He will say, I am feeling difficulty in social situations when I am making a presentation, when I am in maybe interacting in social situations, wherever situations where I am being a center of attention, discussing with people, eating in front of people, talking to opposite sex, etc. Different situations. But when you probe into, you will understand that not that I feel anxious, at the same time, I also feel that others will notice me, they will negatively evaluate me, I will become a sorry figure or an embarrassing figure, and that makes me more difficult and makes me avoid those situations. So, that is a crux there. So, I will rule out this also. Now, agoraphobia. Many people may have a doubt that the answer can be agoraphobia, because agoraphobia, the subject has difficulty in lift, crowded place, public transport, etc. But what is the key feature in agoraphobia in all the situation? It is not that about lift, it is not that about crowded places, it's not that about public transport, but what is common is that the subject fears in being in situation where he perceives easy escape is not possible or like trapped. So, it is not that a patient with agoraphobia has the problem is that it is not that fear of being in lift, fear of being in a closed room, fear of being in a crowded bus, etc. Actually, the key connecting feature is fear of being in situations where the subject perceives that I am trapped or I cannot escape. It can be a big busy mall, it can be a locked room, it can be a crowded bus, it can be an elevator, or all any situations, maybe in a classroom where I am sitting and I feel I am trapped. I cannot go outside. I feel trapped. That causes marked distress to the individual. Specific phobia. In specific phobia, the subject has phobia in specific object or situation. Maybe like blood injection injury, maybe animal, maybe environmental, maybe any life events, etc. So, specific maybe fear of particular, etc. And one more important thing, what is a phobia? So, specific phobia is phobia in specific event or object or towards situation. But what is a phobia? What is a common feature? Is it just simply a fear? No. Phobia is excessive and out of proportional fear, often irrational. So, excessive, irrational, out of proportional fear towards object or situation, etc. And what happens because of this phobia? They lead to active avoidance. Because of this, the subject leads to active avoidance and cause marked distress and dysfunction to the individual. So, this should be excessive, out of proportion, and often sometimes irrational to fear compared to what is in that culture, and that should lead to active avoidance of that situation, object, etc. They will anticipate even the slightest and try to avoid, etc. Active avoidance and cause marked distress and dysfunction. So, there can be agoraphobia, there can be social phobia, etc. There can be specific phobia. Particularly in specific phobia, it will be specific, this, etc. So, with the available information, this is the since birth scared of elevator. So, here this particular specific thing that is only mentioned. When you take in agoraphobia also, some people have the difficulty in being in lift. But not only that, will be not just simply limited to lift alone. That will be in all situations where they perceive they will be trapped. So if a question they want an answer of agoraphobia, they should have difficulty traveling in the lift or going to park or public places or in traveling in the bus, etc. If that was the question along with elevator, all these things were there, I would have gone for agoraphobia. But now specifically mention only lift, I go for specific phobia. Just to avoid, I hope to avoid a confusion that it is not because going up in the lift at the height is fear. They have also added that he prefers to going in stairs to height. So I don't think this person has a fear at height, but this traveling in the lift alone is only a problem. And no chance for social phobia here, where there should be more of a socializing situation, embarrassment, things should come into the question. So that is ruled out. So in that way, I can go for specific phobia. Coming to question number 6. A patient after getting operated for appendicitis, so there is an evidence of surgery happening, post-surgical, developed confusion, hallucinations. His wife informs that he takes alcohol occasionally. What could be the most probable condition? So, delirium is one of the important thing you should understand. Delirium is actually a medical condition with psychiatric manifestations. That is what the way you should remember. A medical conditions with psychiatric manifestations. Many times in our PG life, we remember there is a tug of war between the medicine PG and psychiatric PG. It is your case, it is your case. So, this is a medical condition. Actually, it's a medical condition with a presentation of symptom that comes in the purview of psychiatry. So, what happened? There is a disturbance in awareness and attention. There is a clouding of sensorium. All this happens. So, there can be attention, orientation, memory disturbances. Usually, it's acute or subacute onset. It is not something for years of it happens in a span of just in a few hours to days, or that happens delirium. It is a fluctuating cognition that is happening, fluctuating phenomenon. It's a fluctuating cognition. The patient may be like was okay in the morning, but as evening it comes, sometimes it worsens. That is called as sundowning. Sometimes worsening in the evening. That is happening. What is called as sundowning. Worse in the evening. There can be also psychomotor disturbances. So many people think that in psychomotor disturbance means the patient should be restless, hyperactive. Many cases like drug withdrawal, all those things, you get an hyperactive delirium. Whereas due to medical metabolic causes, many times sometimes you get hypoactive delirium where the patient is not responding at all. Whereas in hyperactive may be a restless, rambled speech, irrelevant speech, talking more, restless, etc. So anything can happen. They can have also psychotic symptoms, fleeting delusions, hallucinations, etc. will be there. So many times the patient will be appearing fearful, etc. So then the medicine PG used to tell, see, he is fearful, he says somebody is there, that is something else, etc. He is looking at a bunch of file and tell that a man is standing there. He is telling that somebody is coming here, somebody is flying here, etc. So this all psychiatry your case. So, but the presence with psychiatric symptoms, fluctuating cognition, psychomotor disturbance, acute or subacute condition. And many times there will be a risk factor. There will be sometimes drug withdrawal, sometimes he may be alcohol dependent who is now in the withdrawal phase. Many times alcohol dependent patient who get admitted following some fracture to surgery in the 48 to 72 hours, as we learned timeline, they can develop delirium tremens. Post-surgical, they may be on multiple medications, multiple medical comorbidities, electrolyte imbalance, etc. Post-surgical infections, lot of things. Sometimes even in ICU, they can develop this sort of symptoms. So, getting operated post-surgical, then drug withdrawal, all those things will focus on the presentation on delirium. Alcoholic hallucinosis, we understood that after 8 to 12 hours, this presents with hearing voices, but no confusion. It is in a clear sensorium, clear orientation, they start hearing voice. That is a differentiating feature from delirium. Acute transient psychosis, is also they starts with the acute onset. They may present with the psychotic symptoms following emotional turmoil or stresses, but no such confusion or disorientation that doesn't usually happen. Mania will show with persistent elevated mood, increased energy, increased talk, etc. So, considering the question given to you as getting operated for appendicitis, the presence of an infection or a surgery, etc., in the view of infection, derangement, etc., maybe history of drug, etc., the presentations typically with a confused picture typically should go for delirium than any other acute and transient psychosis or anything. This should be the typical consideration. There will be confusion, attention and awareness disturbance, orientation problem, etc., which is not the feature of ATPD or acute transient psychotic disorder, where it's an acute or abrupt onset of symptoms with emotional turmoil, psychotic symptoms with us following a sudden stressor exposure, but the patient will be in an intact sensorium. There is no confusion. It is an intact sensorium. The patient will be clearly oriented into the environment, but the psychotic symptoms are prominent here. But the confusion, all those things, the disorientation, the attention and disturbances, awareness disturbances, all those things can be present. So that is what you should know about delirium. Delirium can occur due to multiple causes, medical and drug related, etc. Not due to psychiatric cause. It is actually a medical, it is secondary to a medical cause. So it can be a drug withdrawal, drug intoxication. It can be due to some medical conditions, infections, electrolyte imbalance, post surgery. These are the common scenario. You get it. Coming to the last question, the seventh question. A child with IQ appropriate to his age, normal learning skills, poor in mathematics, getting poor mark in it. What is the diagnosis? So here you rule out intellectual disability because his IQ is normal. So when I evaluate a child for this, there are few things which I wish to look into. First thing, I want to see whether his vision and hearing are normal. Second thing, I want to know whether he has adequate environmental stimulation. See, you are all sitting here and preparing for entrance examination, etc. How have you come to this level? Had you problems with vision and hearing, it would have been difficult for you. Even if things were normal, the parents have not sent you to school, not even, you don't know even writing, they have locked you in somewhere in a house or room and nothing, no exposure to the outside world. How would you have been? You could not be able to do it. So when you get normal vision, hearing and your adequate environmental stimulation and your brain is having acquired the intellectual and adaptive functioning, your intelligence is normal. That is, you start learning, reading, comprehension, your brain is also working properly, no deficits, no chromosomal anomalies, no structural anomalies, no deficits, nothing happened and everything is intact by God's grace. Your learning, language, comprehension, counting is fine. You learned adaptive practical skills like social communication, knowing each other's feelings, reacting to the environment, the way you should behave, how to spend money, how to manage things, etc. All those behaviors. So all this together made you independent. As you grew, you became independent to function according to needs of society. But there are some people who have difficulties in this intellectual functioning and this adaptive functioning, where that is called as the intellectual development disorder or intellectual disability. Previously, we call it as mental retardation. So just by telling that in this question, like IQ is appropriate to the age means, okay, we rule out intellectual disability. His learning skills are also fine. But he is having a specific area problem, like writing, reading, calculation. So there comes specific learning disability like dyscalculia, dyslexia, dysgraphia, etc. So in dysgraphia, they may be having the difficulty in written language. In dyslexia, they may be having difficulty in the words, letters, reading, all those things. In dyscalculia, specifically in the math, calculation, counting, number system. Other areas will be fine. So this is called a specific learning disorder. So, and it is not an exam phobia because only because he may have fear towards mathematics later, but anyway, the thing is that here it is the problem is with that particular area. He may be having no problem with exams, writing his exams in English or language or other things because he is able to do that well. But this area he is not able to do. Now, two other choice, so pretty straightforward. So, two other choice ADHD and autism. So, ADHD is attention deficit hyperactivity disorder where the child will present with difficulties in attention, then hyperactivity and impulsivity. So, there the question will be given to you to be a child who is restless, difficult to manage, not able to keep quiet, easily forgetful, not able to do task with attention, lot of things. In autism is a disorder where there is impairment in the social communication, emotional reciprocation, etc. The child will be like in his own world and there will be poor social communication or emotional reciprocation, etc. So, this is entirely different scenario. So, considering this choice, this child who is having appropriate age, having a difficulty in a particular area is having a specific learning disability disorder, particularly related to the math, the calculation, dyscalculia, etc. So, this is what you should remember. So, before that, intelligence, intellectual disability, learning disability, all those conditions the child when you assess, ensure that he is having normal vision, hearing, sensory modalities and has also has adequate environmental stimulations. She is having facility for adequate environmental stimulations. Then consider his intellectual functioning and his adaptive functioning. If those also normal, then consider his any difficulties in particular area, etc. ADHD comprises another area where he is restless, hyperactive, not able to concentrate as if driven by a motor, whereas autism refers to a child with difficulties in social communications, emotional reciprocity, understanding emotions, and be a child in his own world, remain aloof, alone. So, these are the important questions of the FMGE that we have discussed. So, I hope you have got a basic understanding of the things. So, to conclude, understand the question, read the question well, try to eliminate in case like you are not able to reach a conclusion, try to eliminate and try to find out the best answer among the available choice. So, this is also an important skill, the art of elimination. In case you are confused, it's not like you try to remember the correct answer and pick. The art of elimination is also very important in entrance examination. So, I hope you have enjoyed the session and had a good learning experience. Most of the questions have been covered in the classes and in the notes, and very happy to see that almost many questions that has come are being taught or discussed, the concepts being discussed. So, and specific areas are now particularly like addiction, OCD, anxiety spectrum, etc. are now getting more and more questions seems to be coming up. So, in this session, we are going to see the FMGE psychiatry questions of the 2021 year, June and December. So, there are about 8 questions of psychiatry of the June and December 2021 series of FMGE. So, let us see the important topics one by one. So, the first question is from the chapter the gender dysphoria, sexual dysfunction, paraphilic disorders, which I have discussed in the class, where the question is about uncontrolled and excessive sexual desire in man. So, there are 4 options: voyeurism, sadism, nymphomania, satyriasis. So, excessive and uncontrolled sexual drive or desire. In man, it is known as satyriasis. In woman, it is known as nymphomania. So, excessive uncontrolled sexual desire in man, it is satyriasis. In woman, it is nymphomania. So, you have seen two other options. One is the voyeurism and the sadism. So, these are called as the paraphilic disorders. An important area, paraphilic disorders, are often asked in entrance examination. So, let us see what are the paraphilic disorders. So, I am not going to explain much about the paraphilic disorders, whatever it is, because I have already discussed in the class previously in my lectures, it's available. But let us see the examples. One is friteurism, that is sexual gratification by rubbing genitals or the penis on non-consenting female body. That is called as friteurism. Voyeurism is also known as peeping Tom. Gratification by peeping or watching people naked or dressing, undressing. I am just trying to put in simple terms, or sexual activity. So, just by watching or peeping, this people gets satisfaction. So, friteurism, voyeurism, exhibitionism. Here the gratification is by exposing one's genitals. Sadism and masochism. So, here the sexual gratification is by inflicting or being inflicted physical or psychological suffering. So, in sadism, what happens is by inflicting suffering on the partner, whereas in masochism, by being inflicted suffering, that is made to suffer by being beaten, being injured, etc. Whereas in sadism, it is by inflicting onto the individual. Pedophilia. Here gratification is by having the sexual relation or gratification on prepubescent child. Transvestism. The gratification is by wearing clothes of opposite sex for gratification. For gratification of their sexual need, by the arousal is by wearing the clothes of the opposite sex. And last comes fetishism. The gratification by inanimate objects related to body parts like shoes, socks, etc. are used to achieve gratification. So, these are the 8 important paraphilic disorders. So, friteurism, voyeurism, exhibitionism, sadism, masochism, pedophilia, transvestism, fetishism. There are a lot in the list, but the DSM-5 recognizes about 8 major ones, and at the same time the nymphomania and satyriasis. So, coming on to the question again, the uncontrolled and excessive sexual desire in man, it is satyriasis. If it is female, the answer would have been nymphomania. And gratification by injuring or inflicting injury, physical or psychological suffering on the partner, it would have been sadism. If achieving sexual gratification by peeping into people, undressing, having sex, or grooming, being naked, etc., that is called as voyeurism. So, this area is an important aspect often asked in entrance examination. Coming on to second question. A patient had COVID infection about 3 months back. Now, he presents with complaints of excessive sweating, palpitation, fear that he is going to die. So, excessive sweating, palpitation, and fear that he is going to die. The physical examination and investigations were done, but no abnormality. What is the diagnosis? The options given are post-traumatic stress disorder, depression, mania, panic attack. So, I should say that COVID is supposed to be, it is said that as a joke, like it is a fertile period for a psychiatrist, because post-COVID, lot of psychosocial issues, psychiatric diagnosis, of which one of the important problem was anxiety spectrum disorders, and there is a big surge in depressive as well as anxiety spectrum disorders post-COVID. So, there are different type of anxiety spectrum disorders we have seen, and of this, one of the important entity is called as panic disorder. Very important. So, panic disorder, the features are panic attacks. The patient will have panic attacks. Following the development of panic attacks, multiple attacks, they will start having anticipatory worry of another attack, and gradually that will lead to avoidance of situations to prevent attack. Of if an attack comes, what will I do? Avoidance phenomenon, avoidance behaviors. All this together constitutes a panic disorder. So, panic disorder means the individual will have multiple panic attacks, and this panic attacks frequently come. The patients gradually start developing an anticipatory fear that will this come again, anticipatory worry comes and such behaviors, and they starts having avoidance behaviors, avoids going alone, being alone, or try to anticipate situations where they may have an attack, etc. So, the building block comes to be like a panic attack. So, what are panic attacks? So, features of panic attack is it is an episodic phenomenon, often unpredictable. So, panic attack often comes like an episode, often you cannot predict when it will come. But as you have multiple episodes, it becomes more relatively predictable, but often it comes out of the blue, episodic and unpredictable. And when you develop an attack, it is abrupt in onset. That is unexpected, out of the blue, it suddenly. You may be reading, you may be sitting, you may be singing, sleeping, whatever, you may be traveling in the bus, it suddenly comes. And within a few minutes, it will peak in minutes. In a matter of few minutes, it will peak, it will reach as a height. There will be intense autonomic and somatic symptoms. To put it simple, DSM-5 have mentioned lot of symptoms. In the head, it is dizziness, spinning, etc., fullness sensation or something. From the neck, it is dryness, choking sensation. From the chest, it is pounding, palpitation of heart, not able to take breath, breathlessness, etc. From the abdomen, it is like butterflies in the stomach. From the limbs, it is numbness or paresthesia, hot flushes, chills. A lot of intense autonomic and somatic symptoms. Palpitation, sweating, pounding sensation of the heart, choking sensation, then etc. The subject will have experience of derealization and depersonalization. They will feel the environment around is unreal, that is derealization. They feel detached or estranged from one's own body, that is depersonalization. What is the thing that is going to their mind is impending doom of death or fear of losing control or going crazy. I feel I will pass out, or I am turning mad, or something is happening. I feel I will die now of a heart attack, etc. So all these are the features of the panic attack. The subject will land up in a casualty. Doctor save me, that something is happening. But just before the bloods are drawn, the steth is put or something, immediately the patient after some time will settled. After some time they feel settled. That is called as a crescendo decrescendo pattern. Abrupt onset, peaks in minute, intense autonomic somatic symptoms. After some time it settles down, etc. But during that time the patient is having intense distress. But the patient will even remember better the scenario, because they will understand what has happened, what was that, why it happened. But when more and more it occurs in unpredictable situations, the patient will have intense distress, will fear that he may have again an attack, he will start worrying. He is invited for a marriage, oh, if I go there, if it happens, what will I do? If I go alone, etc. Traveling in bus, if it happens in between, what will I do, etc. So, and gradually he starts avoiding, or that gradually may sometimes set in. So, many times investigations are done to rule out many conditions that can, right from your hypoglycemia to several conditions that can cause panic disorder. Entrance often ask entrance people like mitral valve prolapse, pheochromocytoma, etc., bronchial asthma, hypoglycemia, cardiac conditions, etc., drug withdrawal, sort of things. But you do evaluation, you rule out everything, there is no other cause, but no abnormalities are often seen. So, this is happening. So, again the patient will have this attack, and it requires a psychiatric consultation where drugs, antidepressant drugs, particularly like the SSRIs, etc., are given for with good results. Whereas in acute attacks, you give benzodiazepine. So, when a drug of choice for an acute attack, most of the time an alprazolam or clonazepam or lorazepam, etc., may be given. Benzodiazepine may help in acute attack, curbing the acute attack, but long time it may require drugs like SSRIs. This is what many times post infections, etc., has got a propensity to develop conditions, particularly after post-COVID, we get a lot of cases. So, the intense autonomic symptoms, the fear that he is going to die, and the no abnormality, all this episodic pattern, all this points to the answer of a panic attack leading to a panic disorder, which is an anxiety spectrum disorder. So, that brings us to the second question, and we are going on to the third question. After 72 hours of cessation of alcohol, the following is seen in a person with alcohol dependence syndrome. The typical timeline of alcohol withdrawal, it is very important. So, what are the features of withdrawal of alcohol in an individual? First of all, you should understand two things. It is a withdrawal symptom that again makes person takes a substance again, because when they try to reduce a quantity of substance, they experience a set of symptoms which are physiologically mediated. So, that is why there is a physiological reason why this is happening. We can explain the withdrawal features of a substance because we know what is a physiological process that is happening in the neurotransmitters, and because of this is happening. So, there is a typical withdrawal timeline, a likely mechanism, etc., for all this, any substance, and likewise for alcohol. So, alcohol is a GABAergic agent, and a patient on alcohol is a GABAergic agent. What happens in withdrawal? So, when you stop alcohol, there is a sudden depletion in the GABAergic mechanisms and increased glutamate mediated excitation. And this glutamate mediated excitation occurs, and since there is a decreased GABAergic treatment, in the treatment aspect, what you need is GABAergic agent. Something a GABA agonist agent is required. We will come to it. So, what is a typical timeline of alcohol withdrawal? A person who is having alcohol dependence, when he stops alcohol, in 6 to 8 hours comes tremor. So, tremor is the earliest symptom usually reported. After tremor, in 8 to 12 hours, the symptom mentioned is alcoholic hallucinosis. So, what is there in alcoholic hallucinosis? The patient starts hearing voices, derogatory voices, threatening voices, etc., when nobody is around, and he will be hearing this in clear sensorium. That is one of the important points in alcoholic hallucinosis. So, 6 to 8 hours of last drink is the usual timeline of the earliest symptoms of tremor, and 8 to 12 hours you get alcoholic hallucinosis. So, in alcoholic hallucinosis, the subject starts hearing voices when nobody is around, but loud sounds or derogatory voices, threatening sounds, etc. And the patient will be in clear sensorium. The patient is aware that what the person is doing, he is very clearly oriented, but he starts hearing voices, looking around, nobody is there, but threatening voices, and it will make him frightened. 12 to 24 hours is the usual reported timeline for withdrawal seizures. Usually it's of GTCS type, generalized tonic-clonic seizures. And in a span of another 4 to 6 hours, again, another set of seizures again comes. Then in a span of a few hours, like 4 to 6, another set of seizures. This is known as cluster seizure. It is not a strict rule that it will come only after 12 hours. Sometimes early, like 6 hours or something also. As early as 6 hours, they say that 4 to 6 hours even, it can also happen. But usual timeline they say is 12 to 24 hours. And when it comes to 48 to 72 hours after the last drink, there develops a major condition called as delirium tremens. So, what happens in delirium? In delirium, there will be loss of awareness or attention. In delirium, alcohol withdrawal delirium, there will be clouded sensorium, disorientation, autonomic hyperactivity, tremor, palpitation, sweating, increased BP, etc. Autonomic hyperactivity, increased sympathetic drive, psychotic symptoms like fleeting delusions, somebody is trying to harm, hearing voices, hallucinations, visual hallucination. Typical classically described is visual, can have auditory, etc. But classical characteristic description is visual, but visual and auditory always happen. They will also have perceptual disturbances like the hallucination, illusion, etc. that can all happen. It's a condition having high mortality. Death can even happen. It is a condition having high mortality. Cardiac arrhythmias, death, etc. even can happen. So, this is very important. So, 6 to 8 hours tremor, 8 to 12 hours hallucinosis, 12 to 24 hours withdrawal seizures, 48 to 72 hours delirium tremens. Delirium tremens, all this timeline typical feature diagnosis is important. How will you distinguish between the delirium tremens and hallucinosis? The patient will be in clear sensorium in hallucinosis, whereas in tremens, there will be clouded sensorium, disorientation, autonomic hyperactivity, all those things. It is also good to know something called as SIVA AR scoring. The Clinical Institute of Withdrawal of Alcohol revised score the components. There will be tremor, there will be anxiety, nausea, orientation problems, sweating, headache, agitation, which you can remember by the code as TANOSHA. Tremor, anxiety, nausea, orientation problems, sweating, headache, agitation, plus visual disturbance, auditory disturbance, and tactile disturbance in the form of hallucinatory experiences. So, TANOSHA, VAT disturbances like tremor, anxiety, you can remember like tremor, anxiety, nausea, orientation, sweating, headache, agitation. TANOSHA is a code you can remember, plus VAT disturbance, visual, auditory, and tactile hallucinatory, those disturbances, illusions, hallucinations, all those perceptual disturbances can also happen. So, these are the typical withdrawal features. So, not only just tremor, along with the tremor, it's like a package, you get a lot of other symptoms. So, this idea and the timeline you should have. SIVA score is a scoring we used to put it, and for serial, every day we look the score and watch for the improvement or reduction, etc., along with our treatment. So, coming back to the question, this 48 to 72 hours cessation, a patient, what you expect is the delirium tremens. The 6 to 8 hours is the early sign for that tremor and other features. 8 to 12 is for hallucinosis, and 12 to 24 or as early as 6 hours, but 12 to 24 is a timeline for this, whereas 48 to 72 hours is a timeline for delirium tremens. So, going on to the fourth question is again also related to alcohol. The earliest symptom of alcohol withdrawal, as we have already discussed that SIVA AR score, TANOSHA, etc., we have the code, etc., we have discussed. So, tremor is the earliest symptom that can happen, and that is why many people who use consumes alcohol often say, doctor, I try to stop alcohol, but when I develop tremor, I am developing tremor. Or sometimes some people say that, hey, doctor, I don't have tremor, so I am not an addict, etc. So, many people think that tremor is a feature of addiction, etc. So, this is one of the important features. So, tremor is an important feature. So, hallucinations, the hallucinosis, as we discussed in the previous question, the 8 to 12 hours is alcoholic hallucinosis in clear sensorium, the hallucinatory experiences. Seizures, obviously the 12 to 24 hours, and 40 to 72 hours is a delirium. So, I again say that timeline of withdrawal is very important. 6 to 8, the tremor and the related symptoms. 8 to 12, hallucinosis, what we say, hallucinosis in clear sensorium. 12 to 24, usual timeline for seizure, a GTCS type, and 48 to 72 hours after last drink, the delirium tremens happens. So, very important. So, the earliest symptom is for alcohol withdrawal in a dependent patient is tremor. Again, it was like a alcohol special edition or alcohol special psychiatric questions for 2021 June December FMGE. A focus was, I think, much importance is given to alcohol in this session, substance use. So, here the question was about delirium tremens. A chronic alcoholic patient develop delirium tremens after stopping alcohol, patient should be treated. So, the first and the foremost thing you should understand, it is an emergency. So, what is happening in a patient with alcohol withdrawal in delirium tremens? So, he will be in a disoriented, confused state. There can be autonomic imbalance, can have electrolyte imbalance and metabolic derangements, etc. Lot of things. Dehydration. So, all lot of problems can be there in this patient coming to a casualty. At the same time, as a psychiatrist who has an idea of the neurobiological process, we know that there is an increased glutamate mediated excitation plus decrease in GABA. So, what all thing you should do? First thing is the airway, breathing, circulation, stabilization is the first and the foremost thing. We want the patient alive. So, the typical, we know that the typical things we often repeat like a routine in surgery, all those cases. The first and the foremost, you do the airway, breathing, circulation to IV large bore cannula, blood for investigations. You take your CBC, LFT, RFT, RBS, blood sugar, etc., sodium, all those things to look for any electrolyte imbalance, all those things you will do. Now, hydration plus supplements. So you need to give fluids, and there will be deficiency of vitamins, particularly like the thiamine B complex. All those you know very well. Alcoholics can have malabsorptions, decreased intake, poor nourishment. So there will be much problems with the thiamine. And thiamine is very important in the carbohydrate, that is glucose metabolism. So here you need to give thiamine IV. Also, if you give dextrose, without thiamine, it will worsen thiamine depletion, because this is one thing you should very, very important. Don't simply give thiamine, don't simply give dextrose without thiamine supplementation, because already we presume that there is a shortage of thiamine. We require large quantities of this thiamine. We give 4 to 5 ampules of this polyvern, optineuron, etc. in saline, we give. But simply don't give, or even can give DNS, but with supplementation. But don't simply just give dextrose without any thiamine, because for the carbohydrate metabolism, thiamine is required. So already there is a depleted, so more and more get thiamine used up. And even it can lead to condition called as Wernicke encephalopathy. So thiamine depletion can lead to Wernicke's encephalopathy. The features are GOA, that is global confusion, ophthalmoplegia, ataxia. So be careful that you need to give thiamine. So you can give hydration also, NS or DNS with thiamine supplementation, etc. used to give. You take an investigation, you ensure hydration, you look for the reports comes electrolyte imbalance, all those things should be important. This is to be given. At the same time, the patient is in delirium tremens. So you need to management of symptoms. It is because the DT features, the excitotoxicity, all those happening because of due to increased glutamate. We need GABAergic agent, and those GABAergic agent we give as benzodiazepine. Among benzodiazepines, it comes like chlordiazepoxide, diazepam, lorazepam, etc. Now, what is the advantage of lorazepam and oxazepam? Many cases, the patient may be having deranged hepatic status. So, lorazepam and oxazepam are agent, unlike chlordiazepoxide or diazepam, are hepatically safe. No significant hepatic metabolism. So, they are hepatic safe, or when the status of hepatic status is unknown, these could be the options. Particularly the lorazepam is a drug we often give, particularly if you don't know the status. But diazepam is more longer acting and may require less frequent dosing compared to lorazepam, which has relatively low cerebral T-half and may require more frequent dosing, but that can be safe. We have all discussed this in my notes, in my lectures on substance use disorder. So the treatment that you require is adequate hydration with a good amount of thiamine IV plus IV route of benzodiazepine, preferably lorazepam, if the hepatic status is uncertain, deranged, etc. So in delirium tremens, in these conditions, you require lorazepam and IV supplementation of thiamine. That is very important. So when this patient used to come, automatically we used to do a SIVA score, we used to assess the vitals, large cannulas will be placed, RBS will be checked. If everything is fine, NS with the 4 or 5 ampules immediately of or 100 ml or 200 ml saline, immediate ampule of 4 or 5 ampules of optineuron, injection polyburn, something will be, thiamine will be given. Then Benzodiazepines, if hepatic status everything is fine, diazepam, if not sure also at lorazepam at least will be given, and in adequate doses. There are various regimens which I am not going to it, but that's an emergency, and meanwhile other results will come, watch for other features etc., and the dose will be gradually titrated. That I am not going into in detail, but this is the thing that is required. So lorazepam and thiamine supplementation, benzodiazepine and thiamine, very important. So delirium tremens, very important. So you have seen few questions about alcohol withdrawal timeline management. It is a very, very important. Decrease GABA, increase glutamate, the timeline of symptoms, the management of steps, what is the emergency, complications. This is very, very important. Often encountered in clinical practice and often asked in entrance examination. One of the favorite questions. Now we are going on to sixth question. Which of the following is not a symptom of panic attack? So previously we have seen a question about a COVID patient post-COVID developing panic symptoms and panic attacks, in which I have explained very clearly. So if you remember that, you know that this is a sudden condition that is episodic. That is episodic paroxysmal anxiety is another name. So abrupt onset, episodic, peak in minutes, has intense autonomic somatic symptoms, crescendo, decrescendo pattern. After some time it settles. And they can also have derealization, depersonalization. Along with that, they also develop fear of going crazy, losing control, and I am going to die, impending doom of death. So these are the features of panic attacks. When multiple attacks comes frequently, they start to have anticipatory worry and avoidance behavior, where it constitutes to be a full-blown panic disorder. So which is not a symptom. So suicide attempt is not a symptom related to panic attack. That is not related anyway to panic attack. So these three things, sudden anxiety, the episodic anxiety, and feeling of impending doom are the features. So which is not a symptom of panic attack, suicide attempt is not a symptom of panic attack, whereas all the other three are features of panic attack. So that is very clear. So panic attack and panic disorder is also now frequently asked in entrance examination. These are important areas like alcohol withdrawal. Coming on to the seventh question. So a question on depression has come. 32-year-old female presented with symptoms of mild depression for first time. What should be the initial treatment? So mild depression. In ICD-10, based on the symptom profile, they used to classify into mild, moderate, severe, etc. In severe depression, the patient may have suicidal thoughts, etc., which is an emergency of management. In moderate, also the patient may having marked suffering. Whereas in mild depression, and the first episode, it is having the first episode of depression. So in this case, we can try for a non-pharmacological, that is a psychotherapeutic interventions. One of the important therapy is cognitive behavior therapy. The propounder, the major person was Aaron T. Beck. See, behind our several actions, there are some thought process that is happening in simple terms. This errors in thinking can also affect your or have an impact on your action. So these are to be corrected, these are to be identified, these are to be corrected, etc. That is very important in this, and that is one of the basis for the cognitive behavior therapy, where the underlying thought process, the errors in the thinking. So in simple terms, I'm explaining like the errors in the thinking, etc. are. So there are something called as cognitive distortions, etc. So this is CBT is one of the important psychotherapy principle applied for in several conditions. So you should also know about the triad of Beck. Beck has postulated that in depression, the individual may have a negative view of self, negative view of environment, negative view of future. Negative view of self. I am good for nothing. Things I am not able to this. I am not good. That is called as worthlessness. Negative view of environment. That is called as helplessness. This is not going to. Nobody is able to help me. I won't be able to. Nobody is able to help me out. I won't receive a support from the environment. A negative view of future. Things won't improve in the future. Things are not going to improve. It are going to become worse. This is called as hopelessness. Helplessness, hopelessness, worthlessness. So psychotherapy in many cases will be really helpful. So now coming on to the practical part. So I'll be assessing the patient. I want to see how her depression is. She is having a syndromal depression. Is it mild, moderate, or severe? Is it moderate or severe, or having like suicidal thoughts, marked impairment, etc.? Or is there multiple episodes in the past, strong family history, etc. there? How it is going to impact her current functioning, how severe it is. All those things will make me help her. A combination of pharmacotherapy and CBT, that is the best treatment. But if I am getting a mild depression, if I am getting a sort of a patient with a mild depression first time, and able to have good support or able to understand, has a good cognitive level to cope up with the therapy, able to with therapy. In that case, she is able to with the therapy and all. Then I will prefer cognitive behavior therapy. Particularly if it's a good candidate, she can. If it is severe or moderate severe depression, I won't consider, because the patient won't be in initial stage, to go for this. I may sometimes be more focused on pharmacotherapy, at least a combination of pharmacotherapy plus CBT. But pharmacotherapy is very important. But in this case, I can assess the situation and take an element of cognitive behavior therapy. So the best treatment modality in moderate to severe will be a combination of CBT plus antidepressant, where antidepressant is important, plus CBT can be done. In severe cases, antidepressant will be the first thing. After time, they may also go to CBT. Initially, they may not be able to cooperate with that. Whereas in severe depression, not responding to antidepressants, suicidal ideas, recurrent, it's causing distress. In that condition, I may even consider the shock treatment, or what is called as electroconvulsive therapy. So severe depression in catatonia, severe suicidal ideations recurrently happening and not responding adequately to antidepressant trials, etc. There, in that case, electroconvulsive therapy is also useful. So if this question was having not responding to antidepressants, severe depression, multiple episodes, suicidal behavior, catatonic symptoms, etc., there I would have considered electroconvulsive therapy. If it's like a moderate to severe depression that has come, if that was the question, I would have considered CBT plus antidepressant with a focus on antidepressant. But mild first episode, then I may initially will wait with the trial of CBT sessions. So this is what you should understand about the principle. So in this question, the mild depression first time female whom I presume to be have a good understanding and able to cope up with our psychological interventions, can follow up, etc., then I will go for CBT trial after discussion with the patient. So that is about the management, cognitive behavior therapy. Coming on to the last question, the 8th one of this session, that is also from substance abuse. A patient admitted presents with tachycardia, arrhythmia, and scratch marks on the cocaine is a drug that acts by dopamine reuptake block. So dopamine reuptake, the D2 receptors, that reuptake when it is blocked, it will lead to increased dopamine and norepinephrine, etc. The amphetamines also work by increasing dopamine and norepinephrine, but that is by increased release. So the amphetamines, how they act is by the reversing the transporter and increased release, whereas the cocaine group of drug will block reuptake. So both these amphetamines and cocaines increase dopamine, norepinephrine, etc. But the mechanism is cocaine, etc. block the reuptake and thus increase the levels in the synaptic cleft, whereas in amphetamines they increase the release of these neurotransmitters, reversal of this neurotransmitter, increase release into the synapse. So the dopamine increase will cause psychotic symptoms. The norepinephrine will cause autonomic symptoms. So the autonomic hyperactivity is an important feature. That is a tachycardia, arrhythmia, seizures, risk and all will be there because of this autonomic hyperactivity. There is something called as Magnan's symptom, formication, also known as cocaine bugs. So what happens is that there is delusion of persecution plus tactile hallucination of insect crawling. So the patient will experience crawling of insects under skin or sand or insects crawling under skin, that will lead to scratch. So this is also known as cocaine bugs, Magnan symptoms, etc. So this is an important catch. Along with the hyperactive autonomic symptoms, the scratch marks on the skin. One of the important questions they used to ask is about this cocaine. So the tachycardia, the pupillary dilatation, tachycardia, arrhythmia, all the sympathetic symptoms, autonomic hyperactivity sympathetic symptoms plus the scratch marks, they point to what is expected in this question is about the candidate will be able to recognize the Magnan symptoms or cocaine bugs. So the question deals with cocaine. So of this 8 question, you can see it's a mixture from the substance use disorder, at the same time anxiety spectrum disorders like anxiety spectrum disorders, etc. So lot of questions are coming from that area. So this paper, there is a focus on these sort of areas, and you also got to know about the cognitive behavior therapy, treatment of mild depression, etc. So fairly good paper with a lot of questions asked from the notes, and I hope you have scored well this, because a lot of questions are commonly asked and commonly discussed in the class. So I hope this is clear to you, and so learn these areas well. These are important areas and will be often repeated in several examinations. So now in this session we are going to have the discussion of the previous year's question paper of the FMGE exams. So first of all, we are going to see the 2022 FMGE questions. There were 3 questions asked in psychiatry, and let us discuss those questions now. So we will start. Coming on to the first question. So a question was there with a picture of a person washing his hands, and the question was like this: a person repeatedly washes hands shown in the image, and what is the diagnosis or diagnosis is? Seems to be like a pretty straightforward question for your level, and I am even surprised that sometimes even the picture itself was not required. For the sake of adding a picture, they have added a picture. Fine. So whenever I take class about OCD, I often ask students what comes to their mind. So many of them shows washing their hands, washing, dirt, thoughts, etc. are the answers usually given by most of the students. And recently, I remember watching a psychiatric quiz in some conference where they showed the movie Aviator. If you have seen, if you are a movie freak, the movie Aviator, where Leonardo DiCaprio, the famous Titanic actor, he was found to have psychiatric illness, shows frequent washing, the intrusive thoughts, all those coming up, and it was about OCD was the question. What is this disease about was the question, shows about OCD. Okay, leave aside everything, let us discuss what is mean by OCD. So what are the feature of OCD or obsessive compulsive disorder? So OCD or obsessive compulsive disorder has two features. One is obsession, the other is compulsion. Some are present with predominant obsessions, some are present with predominant compulsions, or mixture of both. So what are obsessions? Obsession can be a thought, it can be a doubt, it can be a fear, it can be an impulse, it can be an image. So it's not just a thought, it can be of different forms. I have discussed this in my class lectures and notes. But what are the qualities? These are repetitive and intrusive in quality. Be it thought, doubt, fear, they are repetitive, they intrude into, push into a person's mind. And the person often recognizes this as originate in one's own mind. They often understand that it is coming from my mind. And they often recognize as irrational. I don't know why this is coming to me. They often understand that this is often senseless and irrational. I know it is coming in my mind, it is pushing into my mind, but I don't know why this is coming up, but that keeps coming. And at the same time, the person find it difficult to resist. So these are repetitive, intrusive thoughts, doubts, fears, impulse or image, which are found to be originating in one's own mind, often recognized as irrational and difficult to resist. And many times, they recognize this as ego dystonic. That is, it is against their thoughts, desires and wishes. I don't like this. It is not something which I want to, but it is keeping on coming in my mind. So these are the features. This causes an intense distress in the individual. So what are compulsions? So because of this sort of obsessions, those repetitive, intrusive, feeling senseless, recognized as irrational, ego dystonic and not able to resist thoughts or doubt or fear or impulse or image coming in the mind, causing intense distress, the subject does some motor or mental act to neutralize the anxiety caused. So there can be motor or mental act. That means motor act means doing with your body like cleaning, washing, etc. Mental act means counting, praying, etc. So this is done because of the distress caused by the obsession. That time of intense anxiety, they are forced to do something to remove this, to alleviate the distress or neutralize this distress. But the problem is that the act is not pleasurable. They are forced to do. It is not pleasurable. They are forced to do that. Otherwise, I am not able to concentrate. I am not able to remain calm or peaceful. So this is what is called as compulsion. So these are the features of obsessive compulsive disorder. So there are several type of obsessions. The most common obsessions are, one is contamination, that there is dirt, germs, infestation, etc. Pathological doubt, where they are doubtful that did I successfully do a task, did I complete a task, etc. So that is pathological doubt. There can be intrusive thoughts, the third one. In intrusive thoughts, some intrusive thoughts of harm, aggression, violence, sexual, etc. keeps coming, which the subject cannot control. That is called as intrusive thoughts. And the fourth one is symmetry. So often the most common obsession is often asked. Compulsion. The most common compulsion in Kaplan synopsis textbook, they say in a table as checking more than, counting more than, washing, etc. But there is another part of the sentence, part of the textbook, where the sentence is like the most common obsession is contamination followed by the act of washing, etc. So sometimes there can be confusion, but individually in a table they have seen as checking as a most common compulsion per se, but the most common obsession being contamination. So the features of obsession and compulsion and the common themes of obsession, the order of common themes of obsession are very important. And you should also understand that it is not just a thought, it can be of different forms. So coming on to this question again, the person repeatedly washes hands. So here the diagnosis is OCD or obsessive compulsive disorder, as it is very clear, so we have discussed so far. But since an option about body dysmorphic disorder is given, I just want to tell you that in DSM-5, OCD is included in a new chapter known as OCD and related disorders, which includes 4 disorders like body dysmorphic disorder, hoarding disorder, trichotillomania or hair pulling disorder, excoriation disorder, also known as skin picking disorder. So in body dysmorphic disorder, the subject is preoccupied with a presumed deformity or a defect in body part, that is body dysmorphic disorder. Since an option is there which may sound confusing to you, I just once again mentioned the same. These were all discussed in our notes and the chapter on OCD. It is a very commonly asked question. So OCD, the related disorders, management, all those aspects are very important. So now we are going on to the second out of the 3 questions. The first question is discussed. So the question is this: a patient in the ward is asked, "What is your name?" The patient repeat the same sentence, "What is your name?" So it is like an echo. He repeats the same sentence. So what is this phenomenon? Echolalia, echopraxia, perseveration, circumstantiality. So let us see what is the answer. So in psychotic spectrum disorders, when I discussed a condition called as catatonia. It's a motoric phenomenon. This catatonia can occur with psychiatric illness, can occur with medical conditions, etc. It is called as cat or mental illness, whatever it be. It can is called as catatonic disorder in DSM-5. So in DSM-5, it is called as a catatonic disorder. It can occur as an independent entity associated with medical conditions or psychiatric illness. Okay. So there are about 12 features mentioned, of which 3 out of 12 are important. Should be present. I mean 3 out of 12 should be present for a diagnosis. Since these are already mentioned in our lectures, I am not going into detail, but 2 phenomenon. One is echolalia, the other is echopraxia. So both of these are mimicking phenomenon. Mimicking phenomenon means the subject mimic or imitate the examiner. You can mirror or imitate exactly like the examiner in words I think more than mimicking, mirroring will be a better word, because it's like a mirroring or imitating exactly like that. Or it can be examiner's action. So when it is words or a speech, it is echolalia. When it is imitating or mirroring the examiner's action, then it is called as echopraxia. So if there is echolalia, when the examiner asks, what is your name? The subject also exactly replies like a mirroring phenomenon, mimicking. What is your name? Tell me what is your name? Tell me what is your name? Come on, like that. It's like a mimicking. Whereas in echopraxia, the examiners take his hands and try to put on his head. Like a mirror image, the subject also will take his hand and put on the head. Examiners try to touch his own nose. The subject also takes his hands and touch his own nose. So that is called as mimicking phenomena. So this is what is called as echolalia, echopraxia. Perseveration. What does mean by perseveration? So it is the persistence of a phenomenon beyond the point of relevance. I am asking you, what is your name? Anoop. Where are you coming from? Anoop. So see, that same thing is persisting even beyond the point of relevance. Or sometimes doing an action, it is also, even when it is not required, it is to be stopped, the subject cannot stop but will keep on doing the same thing beyond the point of its relevance or requirement. So this is called as perseveration. Can be seen in several psychiatric illness, like in frontal lobe syndromes, organic mental disorders, psychiatric illness, etc. It can be seen. So one of the common thing they say is a frontal lobe syndrome, where the orbitofrontal cortex is affected, etc. in several cases. Recently, I saw a case of Alzheimer's disease, a frontal variant of Alzheimer's disease. Usually, we know it's a temporal parallel dementia, but in a frontal variant, where the subject was showing this perseveration, the echo phenomenon, etc. were there. So perseveration is persistence of that phenomenon, maybe action or speech or whatever words, etc. beyond the point of relevance, maybe persistence of an action or persistence of that utterance of a word or a speech, etc. What is circumstantiality? So the other option given is circumstantiality. So it is considered to be like a disorder of stream or the flow in the thought and the speech. So here what happens? The subject starts from a point, they starts including all irrelevant details in the speech, or not required things, lot of irrelevant things, etc. in the speech, and ultimately takes a circuitous route, that is, it takes a roundabout circuitous route, that is round route, and reaches the point or the goal. For example, I'll make an example, I'll to make it very clear to you. If you ask me how to prepare for psychiatry, even when I took this lecture, this was my example, how to prepare for psychiatry. So I say that psychiatry is an important area in entrance examination. Every year, say 10 to 15 questions or 5 to 10 questions are being asked. Then I say that, see, we need a lot of psychiatrists in our country. Psychiatry is one of the important requirement. Considering the post-COVID scenario, lot of psychiatrists are required in the country. So mental health is often neglected thing in our country, and many people don't know what is the difference between a psychiatrist and a psychologist. So a psychiatrist is a doctor who has completed his MDBS and MD in psychiatry, treat the disorders. Mental illness means it requires their understanding of the neurobiological phenomenon and neurotransmitters in the brain, etc., etc. lot of things. Then coming back to, while preparing for psychiatry, you should be reading so and so topics, you should be revising so and so topics. These are a set of topics that are asked in entrance examination, etc. So you see, how to prepare for psychiatry was your question. I started with, it is important and about the preparation. Then I started including many irrelevant details about psychiatry, all those things. These are not required now. Whatever I told, these are not required, not pertinent to the question that you have asked, but lot of irrelevant details, unnecessary details, dragging, etc. And ultimately but came back to the same thing. So this is what is called a circumstantiality. For thinking starts from a point, take a circuitous route with lot of irrelevant details, etc. and ultimately comes to the point or the goal. That is called as a circumstantial speech. So, considering the question, the patient is repeating the same sentence like as examiner. This is known as echolalia. Echopraxia is the action, perseveration is the persistence of the behavior or the action, be it action or word, whatever it be, persistence beyond the point of relevance. And circumstantiality is like a disorder in the speech of stream where it takes thinking starts from a point, the thinking or a speech starts from a point, takes a lot of circuitous route with irrelevant roundabout route, like including lot of irrelevant details, etc. and ultimately come back to the point, that is circumstantiality. So, hope that is clear. So, coming on to the third question, you might have seen this picture often in surgical textbooks, I am sure. So, maybe a condition, a patient might have come with abdominal pain, maybe typically, or going back to a bit of surgery, the gastroparesis, features of gastroparesis, stomach obstruction, abdominal pain, nausea, vomiting, etc. Maybe a patient coming here. The surgeon might have examined, then palpated lump, etc. So, something in the stomach, be it malignancy, be it something else. Okay, but looks like something not like the, maybe a difference in the consistency, whatever it be something. So, he will be doing X-ray, abdomen, etc. and ultimately will found out that it is hair coming inside the stomach. So, surgically that is removed. So, I hope, and the question is which doctor is required to diagnose the condition. So, I hope you might have heard of the word bezoars. These are certain like undigestible matter in the gastrointestinal tract, stomach, intestine, etc. So, there can be phytobezoars, there are different things, it can be trichobezoars, etc. So, depending upon the substance, this can be different. So, what are phytobezoars? Phyto may be vegetable matter. Tricho, that is hair. So, how come this hair, all those undigestible matter like accumulating in this individual's abdomen? My memories go back to the college days where our teacher introduced a term called as Rapunzel syndrome. You can Google it and you will find Rapunzel syndrome. A patient having hair mass or bolus in the GIT, stomach to intestine. And if I remember, the name came from the character Rapunzel in the British fairy tale story. Rapunzel is a girl with a very long hair. So likewise, in the imaging and all, you will see a hair or tail like extension of this matter in the intestine. That is what I remember, the name Rapunzel syndrome, etc. So the question comes, how this hair, this masses of hair that is found in your head comes, like you often see this in a barber shop, this hair all kept in the corner, but how does this comes in the stomach? So the patient may be consuming or ingesting mass of hair. That is called as a trichophagy, where the subject consumes hair. It is often seen associated with trichotillomania. So, when I discussed the first question with the OCD, I also mentioned that there are OCD related disorders in DSM-5, body focused repetitive disorders. So, one of them is called as trichotillomania or hair pulling disorder, where the subject is forced to feel intense anxiety and pulls hair from his body parts. And some of these individuals may also exhibit trichophagy, that is consuming mass of hair. So, may not be all, but many, some can have trichophagy. And this what happens? This will lead to the Rapunzel syndrome or trichobezoars in abdomen, cause surgical conditions, and that is called as a Rapunzel syndrome, where subject may be presenting with the features of obstruction, and on evaluation they will get this. So, definitely the person to evaluate them will be a psychiatrist, because of anxiety spectrum disorders or OCD related disorders like this, and they have to manage it. And psychiatrists will evaluate for this sort of conditions, will appropriate pharmacotherapy and psychotherapeutic interventions will be done. So, surgeon has his emergency part of the surgical removal and stabilize the patient, and should be followed by the psychiatrist, who has to rule out the comorbid psychiatric disorders and their management. So, it's a teamwork between the surgeon and the psychiatrist. So, surgeon and psychiatrist. So, following the surgery and the management, the psychiatrist may also have the treatment. Maybe like if they're having this sort of OC spectrum phenomenon, this related disorders, they may sometimes require SSRIs, and they may suppose also require habit reversal techniques to modify the behaviors. Sort of psychotherapeutic interventions will be also be required. So, this comes in the purview of surgeon and psychiatrist. So, hair inside the stomach found during surgery. So, to diagnose this condition of this trichophagy, trichotillomania or associated psychiatric conditions that can cause this sort of trichobezoar. So, this is known as trichobezoar. And the underlying conditions that can be, there is a trichophagy, which may be due to a psychiatric disorder, can have in several conditions including trichotillomania, or so can different conditions can cause this. Even in a disorganized psychotic also sometimes you can may see it. So, whatever be that, a psychiatric underlying disorder should be ruled out. Anxiety spectrum or psychotic or whatever be, it should be ruled out. So, psychiatrist is a person in this. So, with that brings to the end of our this discussion of this FMGE paper. So, thank you all for this patient listening. So, I hope all these 3 questions are clear. Thank you.